So may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as the digital partner for this online event called Neonatal Pathshala Series, hosted by the National Neonatology Forum Gujarat chapter. And the focus of today's session is lessons from expert non-genetic hyperinsulinism, a hidden enemy in NICU. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Kunal Ahiya sir, the Honorable Secretary of NNF Gujarat, to start the event today with his enlightening words and for the further coordination. So the dice is all yours, sir. Please proceed.
Thank you so much, Ritu Parna. So today is a very important topic which we are going to discuss today, and for which we have Dr. Chetan Dave with us, who is an pediatric endocrinologist and a very dear friend of mine. So I welcome you, Dr. Chetan, for this neonatal Pathshala series, which we conduct on every Wednesday between 3 to 4 p.m. So hypoglycemia, it leads to permanent brain damage, and so it is very important, and hyperinsulinemia is one of the very important cause of it. So today I hope you will be enlightened by the knowledge which Dr. Chetan will share with us. So for further introduction, I would request Dr. Vishal Goel, who is the project in charge for the Neonatal Pathshala series. Over to you, Dr. Vishal.
Yeah, thank you, Dr. Kunal. So today's topic is non-genetic hyperinsulinism, and it is a hidden enemy in NICU. So for that, we have a renowned faculty from the Gujarat, and he is doing a great work. If I talk about endocrinology, so he's a Dr. Chetan Dave, and he's a consultant at pediatric adolescent endocrinologist. He's a director of Center of Pediatric Endocrinologists and Diabetic Center at Rajkot. He did a DCH from the VS Hospital, followed by endocrinologist fellowship in Kanpur, followed by two overseas fellowship in endocrinology from Cleveland and Liverpool. And he is doing a great work in, if I talk about the academic, he has a multiple publication and the chapter in the various book. So I welcome Dr. Chetan Dave, and over to you.
Thank you, Dr. Vishal and Dr. Kunal for inviting me. Recently, we got few patients regarding resistance hypoglycemia. So I talked to Dr. Kunal and I told him that let's have a discussion regarding hypoglycemia and what and how we can tackle this situation in an efficient way. So as discussed by Dr. Vishal, I'm sharing my screen and we will start with the presentation. Just a minute. So hypoglycemia is quite common as far as neonatal NICU is concerned. We will talk about a few cases. Is my screen visible?
Sir, it's taking time.
No. Yes.
Yes, now it is. Kindly make it full screen, sir.
Okay.
Thank you.
Fine. So as we know that hypoglycemia is pretty much common in neonatal ICU, and usually the cause or the diagnosis is not sought by many of us practicing neonatology, because usually, or you can say most of time, it is temporary, or you can say transient. But still, we many times stuck after we increase GIR to certain extent, and then we are stuck that now what to do. So let's go case by case. A case of 3-year-old female who got seizures. It was the first episode, and there was no significant risk factor otherwise, or you can say she was full term vaginally delivered. Birth weight was 1.6 kg. So she was full term IUGR, or you can say SGA baby with mother having pre-eclampsia. Initially, she was admitted in NICU for 1 day and then handed over to the mother because of there is no events or no any complications during first 24 hours of admission. So after coming to NICU on emergency, she was given dextrose bolus. She was started on glucose infusion rate of 7, but again she got seizures. So again emergency management was done, and gradually GIR was increased up to 12 mg per kg per minute. So then again her sugars were in 40s and 50s. So as per protocol, she was given hydrocort injection, a bolus 5 mg per kg state, and her sugars were improved and shoot to 140s and 180s. But now the question comes in, what should we do next? Is this cortisol deficiency leading to hypoglycemia? So what is the diagnosis leading to hypoglycemia? Number one, and number two, that how long this hydrocort should be continued. Should it be given IV for next few days, followed by oral, and followed by tapering of hydrocort and see whether hypoglycemia recurs or not? And this is a definitive case of adrenal insufficiency, or this is some transient phenomena. So this is the first and most common case which all neonatologists encounter. So we'll first try to understand the physiology, and then we'll try to sort out this possible solution. Another case, a 6-day-old male neonate comes with an RBS of 24. But this was a born of 1.1 kg birth weight, preterm AGA baby. This boy is in NICU since birth, and now for the first time this boy developed hypoglycemia, and this is asymptomatic. And this boy has got culture proven sepsis. The boy is on antibiotics, but it has got increase in the glucose requirement. So again, as CRP was stable and there are no other new features of sepsis, hydrocort was given 2 mg per kg state, and then RBS went to 210, and then there was a relief from neonatologist that now the sugar is improved. But again, on hydrocort TDS dose, again the child develops hypoglycemia after 24 hours. So again the same question, what is the cause? We know that the sepsis can cause hypoglycemia, but how sepsis can cause hypoglycemia, and what are the effect of sepsis leading to persistent hypoglycemia requiring high GIR? This will be discussing. So this is another common case in which the first few days baby is asymptomatic as far as the hypoglycemia or sugar readings are concerned, and then after 5, 6, 7 days, when the sepsis is deteriorating or sepsis is not controlled, this baby's got hypoglycemia. So we'll discuss the pathophysiology and possible management of these kinds of babies too. In the third case, that 12-hour-old neonate has sugar of 38. So this was a baby with a birth weight of 3.8 kg, history of delayed cry, bag and mask ventilation was given as a part of resuscitation, and currently admitted in NICU, and the baby is on oxygen plus IV fluid and nil by mouth. So this baby's initial 12 hours sugar readings are fine, above 60, and then suddenly next RBS comes as 38. So critical sample was taken as per the protocol, because this baby was admitted at proper level 3 NICU with neonatologist concerning the baby. So critical sample was sent, and we found that the insulin level were low as well as cortisol level were low. So being a low cortisol, this was the critical sample suggestive of high insulin. High means normal. It was insulin level was 2. So normal insulin with low cortisol. So being a low cortisol, the baby was given hydrocort, and there was a partial improvement in sugars. Partial means the sugars were around 60, 70. So again, we'll be discussing glucose cutoff as well, but this is what partial improvement means. So considering detectable insulin at the time of hypoglycemia, diazoxide was again started along with the hydrocort. So sugars were improved after 24 hours of diazoxide, but the oxygen requirement increased and baby was put on ventilator because baby was not maintaining saturation on oxygen or nasal cannula or high flow oxygen. So again, what went wrong? Whether we did a mistake by starting hydrocode, or we did a mistake by starting diazoxide, or there is some other clue, other you can say factors which leaded to hypoglycemia. So this all we'll be discussing. So these three cases, I think, first case was SGA baby, which is common in neonatal NICU. Second was sepsis, which is again common, and third is birth asphyxia. So these three are frequent encounters as far as the NICU practice is concerned, and all three can develop hypoglycemia, which is also a well-known fact. But majority of the case are transient, and they come out in next 48-72 hours by just increasing the GIR. But what happens if these babies are deteriorating as far as the sugar control is concerned? So if we see the hormonal regulation of glucose homeostasis, we have four plays that can increase the glucose levels, and we have one player, that is insulin, which can cause decrease in the glucose. So we know that whenever we have low sugar or we fast, then first mechanism is glycogenolysis, which can provide sugar for next 6 to 8 hours, maybe 6 to 10 hours. After that, the glycogen content of the liver is depleted. Next come is gluconeogenesis and lipolysis. So these two can provide sugars for next 10 to 24 hours. After that, there is fatty acid oxidation, which is leading to the formation of ketone body, and these ketones are an alternate source of energy. So this ketone is important as far as the brain is concerned, because brain can utilize only two substances. Most is common or most important is glucose, and second is ketone. So glucose and ketone are the essential as far as the brain function is concerned. So whenever we have glucose depletion, ketone comes handy. So what does insulin does? Insulin inhibits these all four steps. That's why those hypoglycemia associated with hyperinsulinism are low ketotic, or you can say hypoketotic hypoglycemia. But this is a danger science, because for the same reason, hypoglycemia due to hyperinsulinism are more dangerous to brain, because brain doesn't get ketones as well. So that's why hypoglycemia is considered as dangerous as compared to hypoxic brain damage. And this is the reason. So that's why hyperinsulinemic hypoglycemia, we should be taking care as soon as possible. All hyperglycemic hormone, including epinephrine, glucagon, cortisol, as well as GH, some or other increases this step, thereby producing more ketone bodies. So this endocrine deficiency, or you can say hypopituitarism or cortisol deficiency, will not cause much damage, because they will leading to ketone body formation, which brain can use. And also there are four hyperglycemic hormones. So any single hormone deficiency will not cause hypoglycemia. We need at least two hormone deficiency to have hypoglycemia. And if we think of this four hormone, cortisol and GH, these both are controlled by the hypothalamic pituitary axis. So only hypopituitarism can cause hypoglycemia. Isolated cortisol deficiency, or even you can say adrenal insufficiency, particularly congenital adrenal hyperplasia or other variants, mostly will not cause hypoglycemia. That's why many neonates presenting on on second or third week of life with adrenal crisis, they will have low BP, hyponatremia, hyperkalemia, but their glucose might not be affected. And this is the reason, because in those kind of patients, glucagon, epinephrine, and growth hormone are high. So they will be taking care of the glucose homeostasis. So two important clinical, you can say, clue take out from this slide is: one, hyperinsulinism will have hypoketotic hypoglycemia, and this hyperinsulinism is more dangerous to brain for the same level of glucose as compared to other hormone deficiency. And isolated cortisol deficiency theoretically cannot cause hypoglycemia. And each and every neonate, as we know that the glucose is transported passively from mother to baby, and so that after cutting umbilical cord, each and every baby experience dip in the sugar. So this blue line is for the full term
Need to
baby,
please unmute other people.
and this green line is for the premature baby. So even full-term
Can
good
you
size
mute
baby also experience dip
Ritu,
in the
can you
sugar.
mute
But after
other
this
people?
dip in the sugar or hyperglycemic hormone comes up, and they will elevate the sugar. And this process takes approximately 48 hours. So after 48 hours, without any risk factor, all newborn babies should behave as normal adult as far as the sugar control is concerned. And that's why the American Academy of Pediatrics has different cutoffs according to the hours of life after the baby is born. So for the first 6 hours, and these are the operational threshold beyond which we should be starting IV fluid or we should take active intervention. So for first 6 hours, this cutoff is 25. 6 to 24, this cutoff is 35. Day 2 of life, this cutoff is 50. And day 3 of life, or after 48 hours, this cutoff is 60. So I think this cutoff should be taken as the operational
Ritu,
threshold as
can
compared
you
to 40 and
mute the
20.
Dr. Jatin? Okay,
Hello?
thank you. Sorry to interrupt.
Okay, fine. Should I continue?
Yes, go ahead.
Okay, fine. So this cutoff should be taken as an operational threshold rather than taking 40 or 20 during first whole 48 hours of life. And another cutoff, whenever you treat for hypoglycemia, means hypoglycemia has already occurred and now you are putting the patients on dextrose, then your cutoff should be 70, not the 40 or 50, because we want that margin of error as far as the glucometers are concerned. So these are the cutoff below which you should be actively searching for the cause, number one. And number two, you should be active as far as the treatment is concerned. And whenever you treat the child, cutoff should be 70. So 25, 35, 50, 60, and 70. This should be the cutoff as far as the hypoglycemia management is concerned. And as we know that the ketones are most important and the first, you can say, diagnostic clue. So any hypoglycemia, any sugar less than 50, first investigation you should send is ketone, in which beta hydroxybutyrate is the most important as far as the evaluation is concerned, because they well correlated with the sugar level. Acetone is last to come and last to go, and even urine ketones are even laster, you can say latest to go. So acetone is not recommended nowadays. The company, one of the company is making that glucometer come ketone meter, in which if you insert the ketone strip, it will measure your beta hydroxybutyrate. If you insert glucose strip, it will measure your glucose. So I request each and every NICU to have that glucometer come ketone meter, which is not very costly. Then ketone strip also cost around 150 rupees or something. So maybe whenever you can even make a protocol in your NICU, and you can convey to the nursing staff that whenever sugar is below 50, first thing you should do is you check the ketone. Because if your ketones are low, we have only three diagnoses. So only three diagnoses of hypoketotic hypoglycemia. One is hyperinsulinism, second is galactosemia, and third is fatty acid oxidation defect. So whenever sugar is low, ketones are even low, then only one investigation you can send is serum insulin. That's why you can cut down the cost as well. Okay, and any detectable insulin above 1 is suggestive of hyperinsulinism. So low ketone, you just send insulin more than 1, you can label it as hyperinsulinism. Now whether it is temporary, transient, or permanent, that is all different entity, but you can diagnose it straight away that this is a case of hyperinsulinism. But if your ketones are present, then you will have a whole lot of other diagnoses which is possible, like all metabolic disorders like glycogen storage disorders, organic acidemia, gluconeogenic defect, or maybe hypopituitarism as well. But as this lecture is dedicated toward hyperinsulinism, I will talk more on hyperinsulinism. So there are clinical clues which are suggestive of hyperinsulinism, like number one, infant of diabetic mother, number two, SGA baby, number three, sepsis, and number four, birth asphyxia. So any stress to the baby can cause hyperinsulinism, and they will develop hypoglycemia at any hour of life. So whenever you find previously good baby improving in all, maybe there is 1 to 2, you can say this predisposing factors like extreme low birth weight, or the patient is not being able to come out of the ventilator, or persistent sepsis, maybe fungal sepsis. Think of hyperinsulinism, in which what you have to do, You just have to take critical sample, go for the ketones. If ketones are low, do insulin, and you will have diagnosis. And you can have diazoxide, which you should be using whenever there is hyperinsulinism. So diazoxide is the first important therapy as far as the hyperinsulinism is concerned. Another clinical clue is requiring high GIR, because hyperinsulinemic hypoglycemia is consumptive hypoglycemia, in which all glucose, whatever you inject, that will be used by this excess insulin. So that's why they will have higher GI requirement. Most hyperinsulinism will have GI requirement of about 10. So if you have any premature, any SG, any birth asphyxia having increase in the requirement of GIR, think of hyperinsulinism. All other, you can say, causes of hypoglycemia, be it hypopituitarism, be it any metabolic disturbances, they will have low glucose requirement. If you inject glucose of 6 to 8 mg per kg per minute, they will have good amount of glucose control. So these are the few practical, or you can say clinical clues which pointing towards the hyperinsulinism. And whenever we have hyperinsulinism, the choice of therapy is diazoxide. But diazoxide has few other points to remember. Number one, diazoxide can cause fluid retention. So along with the diazoxide, we should be given hydrochlorothiazide, not the furosemide, because furosemide and diazoxide will aggravate the hypokalemia. So potassium sparing diuretic, preferably hydrochlorothiazide, should be used along with the diazoxide. But now many recent researches are also coming up that they are saying that there is not much use of hydrochlorothiazide, but for a safer side, you can use low dose of hydrochlorothiazide along with the diazoxide as well. Number two, normal pulmonary pressure and normal echo is must before starting the diazoxide. We have a few incidents in which the baby was on room air and baby got increase in the oxygen requirement. One baby has to go to the ventilator as well. As far as I have discussed another case as well, will be coming to the case after this all discussion. But normal documented echo with normal pulmonary pressure is must for the diazoxide. Diazoxide responsive hypoglycemia, mostly this all transient, or you can say temporary hypoglycemia, will respond very well to diazoxide. So after stabilization of sugars above 70 for 24 hours, then and then you should start decreasing your IV fluid. Many times it happens that we quickly decrease the IV fluid and we quickly put the patient on either what you call RT feeding and all, but no. For the 24 hours, let the patient settle, and after that you either decrease the IV fluid, or you first put increase the RT feeding and then decrease the IV fluid according to the RT feeding quantity. But for the next 24 hours, let the baby settle. And after glucose readings remain above 100, then you should start decreasing the diazoxide. And meanwhile, having a target of RBS more than 70 milligram %. So this is regarding the hyperinsulinism. Now we coming to the first case, that our first patient, that is SGA IUGR baby, in which we started hydrocot, but there was no need of hydrocot, in which the baby was critical sample came late, and critical sample suggestive of low insulin and low ketone. So this is hyperinsulinism of SGA. We have two options for the treatment. If you can maintain sugar above 70 with the GIR of say 14, 15, 16, then maybe this will be reversed in next 1 week. Or you can straight away start diazoxide after having a normal echo. But there is no need of hydrocot in this baby with this kind of critical sample interpretation. Our second case was the sepsis baby given hydrocot, again developed hypoglycemia. So this is called stress hyperinsulinism. Again, it may take 1 to 2 weeks to resolve. But again, this is due to hyperinsulinism and not due to hydrocortisone or cortisol deficiency. So we may be giving hydrocot, but we should be starting diazoxide. And after that, stabilization of sugars and control of the sepsis, we should think of decreasing the diazoxide and taper off from the diazoxide. So this is another non-genetic hyperinsulinism leading to chaos as far as the extreme premature or very low birth weight babies are concerned. The third was again stress hyperinsulinism due to birth asphyxia. Now, the low cortisol is because the cortisol is a steroid hormone. This steroid hormone takes few minutes or say few hours for the adrenal to make it off. So whenever this kind of baby is developed hypoglycemia, this cortisol reserved are used up. So that's why many times cortisol might come low in the critical sample. So here the importance of ketone comes. If suppose insulin is high or normal and cortisol is low, then ketone will differentiate between whether it is primary due to hyperinsulinism or primary due to cortisol deficiency. So again, this baby improved on diazoxide. So the primary cause of hypoglycemia was stress hyperinsulinism, but as the baby might have PAH because baby was on oxygen, this was aggravated by the diazoxide, and that's why baby was put on ventilator due to increased oxygen requirement due to increase in RVSP or pulmonary pressures. So echo is must, and if you have this kind of baby, we have two options. One is increase on the GIR, and whenever the baby is off oxygen, RVSP is normal, then you can start diazoxide. Number two option is second choice drug is octreotide, which is used in diazoxide unresponsive or this kind of cases when diazoxide is contraindicated. Octreotide is an injectable format. It should be given in TDS or QID dose of 5 to 10 microgram per kg, but it has got its own complications. Octreotide can lead to NEC or aggravation of the necrotizing enterocolitis, and it is also the drug having tachyphylaxis. So after 5 to 7 days of octreotide, the effect will go. So try to be very vigilant whenever you use octreotide. So these two are the most important. Earlier, calcium channel blockers were used in hyperinsulinism, but that are not too effective. The last option is glucagon infusion, which is an antagonistic of the insulin. Where I was working in Liverpool, we have tertiary center for the whole UK as far as the hyperinsulinism is concerned. So we have put few babies on insulin pump, subcutaneous pump. But in NICU, you have IV line access, so definitely you can go for insulin infusion, just like other drug infusion. So this is the last option. Sirolimus and rapamycin are mTOR inhibitors, which are newer drugs. It is not recommended nowadays because this non-genetic hyperinsulinism will be controlled with diazoxide 99.9%. So with this, the take-home message is different cutoffs of hypoglycemia for the treatment according to age. So ideally, we should be using them. Blood ketones, or you can say bedside beta hydroxybutyrate, is the first line investigation. Don't give hydrocot unless proven deficiency with high ketone at the time of hypoglycemia, and target glucose should be above 70 while you treat any baby of any baby of hyperinsulinism. So with this, I'm ending my talk regarding non-genetic hyperinsulinism, and I would recommend all to have one ketone meter, which is very handy as far as the hypoglycemia is concerned, and then target of 70. So these two are the final messages as far as the what you call hyperinsulinism is concerned. And if any comment or any question, then definitely I'm happy to take. Thank you. Thank you all.
Thank you so much, Chetan. It was a wonderful session. If there are any questions.
Kunal, can I
Yes, ma'am, please.
ask a question?
Yes, ma'am. I was going to ask you to give a message also.
No, not a message. It was an excellent presentation with a case scenario, Dr. Dave. We are dealing with the similar case just now, and I thought, let me discuss it out. It is a case of really very severe sepsis of 1.6 kg IUGR, and the sugars are fluctuating. So any insulin detectable is an hyperinsulinemia. So I have started with the GIR went up to 12. But
Okay.
now I had a question, like what are the key points to omit the diazoxide?
Okay. So first of all, patient should be off IV fluid. Patient should
Okay.
have. Patient
So
should have.
it is
Yes.
not the normal maintenance fluid, not
Okay.
the feeds, the off IV, like completely off IV fluids.
Yes, completely of IV fluid. Patient should
So
be
till then, I have
maintained.
to continue the diazoxide. My
Yes.
baby
Yes.
has a hepatosplenomegaly, ascites, severe sepsis.
Hmm.
The count, like I haven't seen during the entire tenure. The
Okay.
counts are just total count is 600.
Okay.
So like we are struggling with the sepsis. It's a
Sepsis.
proven Acinetobacter sepsis.
Mm-hmm.
But with hepatosplenomegaly, ascites, severe sepsis, and required a ventilation, now off ventilation.
Okay.
But just now we are struggling with the sugars.
Yes.
So I had
Maybe
the
you
like
should
when
continue
I'll be able to
diazoxide
omit
full
the
dose.
diazoxide.
No, I think you should continue the diazoxide, and as baby have ascites as well, so maybe use hydrochlorothiazide along with the diazoxide as well. And when the baby is off IV fluid, then and then you should think of tapering the diazoxide off.
Okay. But have you seen such severe sepsis where the total counts are 600? It's too low. Almost
Yes.
bone marrow suppression is
Yes.
there.
Yes. So this patient has two risk factors. One is IUGR and second is sepsis. So we have
Yes.
seen hyperinsulinism which lasts can up to 12 weeks.
Yeah.
Yeah.
Okay. But that was a typical hyperinsulin. That
Yes.
is a
This kind
here
of
the ammonia is
hyperinsulinism
also a
with
bit
severe
higher side.
sepsis and
Yes.
stress hyperinsulinism due to sepsis. Yes. In which
Okay.
what we do is if the patient is on off IV fluid, maintaining sugars above 70, 80 on RT feed or breastfeeding or spoon feed, then we discharge the patient with diazoxide and proper sugar monitoring at home as well. We explain
Okay.
them the danger signs, and we call them every third, fourth day to decide the
Okay.
type
So
of
here the hepatosplenomegaly and ascites is part of the sepsis only, not a torch
maybe.
type complex or
Yes,
anything.
yes, and ketones will help. If the ketone is low at the time of hypoglycemia, then it is sure hyperinsulinism. Otherwise, you might think of other metabolic disorders which can lead to hypoglycemia along with the hepatosplenomegaly, not correlative.
We tried to
Correlated
rule,
with the
means we have
sepsis.
ruled out galactosemia.
Okay. BSD
The
can present with this if
beta hydroxybutyrate is normal, and
okay.
but the insulin is detectable insulin at the critical sample.
Yes.
So that we have taken and we have started with the diazoxide. Let's see
Let's
how
see.
it does it. The severe sepsis is one of the major
Yes. And
morbidity.
until the sepsis is resolved, the baby will have hyperinsulinism, which will stand. Yes.
Okay. And central line is preferred till we are less than
Obviously.
10 of the.
Yes.
Okay.
Definitely.
Okay, fine.
Okay.
Thank you.
Okay.
Any other questions by anyone?
Kunal, sorry, Chetan bhai.
Yes.
Okay, the one question is the always I think I just start feeding. The key message can be hypoglycemia. Once you settle, you just start the feeding.
Yes.
But what, like I work also in UK, so they are not giving even the feed once till the hypoglycemia is settled. But
Yes.
over here, we do have a different practice that
Yes.
let's try to start feeding as early as possible. So
Yes.
reason for that only that when you give the feeding and then because of the enterohepatic circulation, the insulin release will be high.
Yes.
That's the reason, or
Definitely.
so there is no any other reason for that one.
No. This is the reason. And that's why I also told that you should be at least on 24 hours for the IV
24
plus
hours, yeah.
diazoxide, and then you should think of even starting the feed. Because what will happen as far as our consultants are concerned, whenever we start feed, we are in a hurry. Chalo, IV fluid.
Yeah.
So this should not be the case. And another thing is due to this insulin release via increting pathways. So whenever you
Pathway,
put
yeah.
something in the stomach, there is GLP-1 analog, and this increting pathway will further release the insulin.
So it
So
is
you
not
mean
going
to
to
say,
happen when you are
Chetan,
Yeah.
you mean to say that when you reach the normal maintenance fluid, at that time you should start the feeds
No, ma'am. Even
when
if
to
it is
start the
high
feeds?
GIR, but still your sugar should be settled for 24 hours.
Okay. So sugar
then-
more
So
than
like
70 for last
70.
24 hours, you can start the feeds.
Yes, yes.
Oh, yes. Okay,
so
fine. That we follow.
yeah.
Okay.
So basically, madam, he's trying to say that if you start at 12 yeah, you will get a good glucose like more than 100.
Yes.
Suddenly we start the feed. So better to cut off slightly GR and with the 24 hours, if you get the more than 70 glucose, then you can
Yes.
start the RT feeds. Am I right,
Yes.
Chetan?
Yes. Sure,
Okay.
sure. Definitely.
The second thing, Chetan bhai, we need the limit of this ketone. Do you have limit or which we call the low ketones or high ketones?
Your
You haven't
your,
mentioned
your voice is
the
not coming properly. So I think you are
yeah.
asking regarding the cutoff for the beta hydroxybutyrate, right?
Yes.
So in ketone meter, the unit is millimole per liter.
Okay.
Okay. So less than 1 millimole is hypoketotic. More than 1 millimole is ketotic.
Okay. So if it is less than one, then definitely we are looking for the hyperinsulinism. Am I right?
Hyperinsulinism.
Okay.
Yes.
Okay,
So
do you have
this,
particular company, reliable company that you can trust on? Because in market, of course, there's a lots of ketone meters available. So, do you have any particular
See,
machine that you are more reliable, more experienced,
in Rajkot and we all are using that Abbott ketone meter. This is very good.
Okay,
Abbott is this dual ketone plus sugar. Plus
okay,
okay,
Abbott.
another advantage is that all strips is coming as single strip. You have to break it down.
okay. Yeah,
So that is
definitely.
also good part.
Okay, thanks. Yeah.
So Vishal, you have a ketometer at your NICU?
Not yet. We haven't faced this much. That's
Chal
why
lai
at least I
laiye.
need a limit. No,
In
it is
Rajkot,
not
I
worry.
have forced all the NICU, all the PICU. In Rajkot, I have forced.
So what is the cost, Dr. Chetan?
150.
See, ma'am, if you
Every
if you
time
if you purchase,
150.
ma'am,
Yeah.
40-50 ketone strips, na, they will provide free of charge. Otherwise, the
Really?
same as glucometer. Yes.
We'll purchase.
Yes.
As such,
Yeah.
what will be the cost of 40-50 strips?
The one strip cost around 140 rupees or something.
No,
Okay.
you should not ask about the phone. You have lots of phone.
Okay.
And the same strip comes in handy if you practice DK as well, because in DK this ketone can be measured subsequently, so that we can have less of IBG as far as the DK management is concerned. So it is of
Yes.
dual use.
Okay. Thank you.
Okay.
Any question from any delegates? We have something on chat box. Okay, no. Where's YouTube link? Okay. So thank you so much, Chetan bhai. It was a really nicely, informative session and starting from the limits and the physiology and followed by the treatment. So you almost cover all the things, and we feel that we are listening to Nelson, something like that, that in detail. So thank you so much, and I think in the future also we are taking more advantage from your side.
Sure.
Thank you, ma'am. Thank you, Chetan bhai. Anything from Kunal?
Yeah, thank you so much, Chetan, for the excellent session. So we had missed for last month to hear from Shwetal ma'am. So I would request Shwetal ma'am also. She is our past president, Gujarat State NNF. So I would request her to say a few words. Please, ma'am.
Thank you so much for providing the platform. I am really missing these sessions, but had certain commitments. And it was like I was determined this time because I'm dealing with such case. So let me have an expert opinion. So thank you so much, Dr. Chetan, for a elaborate discussion on non-genetic hyperinsulinemia, which we really see because day by day, what I have observed now, today only I was talking to the residents. Yet now my nursery is of ELBW and LBW rather than a full-term birth asphyxia. I have just now, most of the babies are less than 1.2, 1.3 kg. And all are IVF delivered or took treatment, IVF treatment and outside, and then they are just, they don't have money and so delivered at the government hospital.
Yes.
So, and they are IUGR. They are they are preterm IUGR. So there is a dual morbidity and risk factors are there. And we should be much more vigilant because one episode of hypoglycemia has a neurocognitive developmental delay. A single episode of hypoglycemia.
Because
The
this all
baby
will
may
be
land up.
hyperinsulinism. Yes, yes.
Yes, yes, yes. So excellent session. We would like to call you again and again
Sure,
for
ma'am.
this your expert talk. Thank you so much.
Sure, sure.
And
Thank
I
you.
would like to
Enjoy
thank
my
Svetal madam also because of her. I think the 3 o'clock Wednesday we all ready to start the session. So because of her, her and also Kunal, so both are doing excellent, and hopefully we can continue for next few years at this long time.
Definitely, definitely. We'll do. We'll do.
Thank you so much, Svetal ma'am. Thank you, Chetan, for the excellent talk. Thank you, Vishal. And thank you, ClearNet, for the seamless experience. Thank you, Rituparna. You can take over. We can end the session now.
Thank you. Thank you, dear doctors, for sharing your valuable insights. And thank you once again for extending us the opportunity to host the session today. And we are definitely looking forward to host you again in another interactive session in the near future. So, with all your due permission, we are closing the session over here. Goodbye, everyone.